The AUA best practice statement on antimicrobial prophylaxis before endoscopic surgery recommends less than or equal to 24 hours of antibiotics for ureteroscopic stone treatment. And I think in the past, people had been more prone to give 3 to 7 days of postoperative antibiotics in addition to a single preoperative dose. The reason we performed the study was to see if we complied with the AUA best practice statement, if we felt that the postoperative urinary tract infection rates were acceptable, so that we could encourage our colleagues in the community at large to adopt the best practice statement of less than 24 hours of antibiotics with ureteroscopic stone surgery. What we found in both this study and in the PCNL study is that for patients without a history of infection, we feel that compliance with the AUA guidelines of less than 24 hours of antibiotics does not appear to increase infection rates over giving antibiotics for 3 to 7 days post-op. There is some survey data out there from some of the sub-societies which suggests that there's room for improvement. And my general sense is that when these best practice statements are put into place, often it's the case that until there's a study that bears out a successful surgical treatment while following the guidelines, sometimes it takes a little bit of time for everybody to adopt these best practice recommendations. The reason we embarked on both this study with my collaborators from the University of British Columbia, as well as the PCNL study with collaborators from the University of Vermont, is that one of the hot public health topics in general today is antibiotic stewardship and the responsible use of antibiotics. And what we're finding more and more in urology and in medicine as a whole is that antibiotic resistance is becoming a greater and greater public health problem. So if we can use fewer antibiotics but still achieve our goals of having minimal infection rates post-op, I think that's a great thing for our community. And so I think we hypothesized that compliance with the best practice statement would result in acceptable infection rates. And of course, we were satisfied to find out that in both of these studies that was true. And I think we can now, based on these pilot data, I think we can confidently encourage our colleagues, for patients without a history of infection, to comply with the AUA best practice statement for antimicrobial prophylaxis for ureteroscopy and PCNL. There are a lot of reports out there of antimicrobial resistance, but one number that I cite to my patients is that if you look in the state of Massachusetts, the resistance to fluoroquinolones, which are very good antibiotics for urinary tract infections and the urinary system in general, for E. coli is anywhere from 15 to 25%, and that's across the state. And those are valuable drugs that we can't afford to lose to antimicrobial resistance. So that's one example, but I think people feel that bacterial resistance to commonly used antibiotics, such as fluoroquinolones or trimethoprim sulfamethoxazole, is on the rise. We cite numbers of 20 to 30% of fluoroquinolone resistance in the state of Massachusetts. And so anything we can do to preserve susceptibility to these antibiotics, including responsible use of them, is what I think should be a common goal of all urologic surgeons. So resistance patterns are different by location, and you're right. So this particular study on ureteroscopy was done just in my patient population in Boston and in Vancouver, and the PCNL study was done in my population and also in Burlington, Vermont. So I think what I would say is, based on the results, I think urologists everywhere performing these procedures can feel confident in adopting these practices, but I think they can also monitor their results. And if they seem to have a higher than expected infection rate, or if they seem to be getting results that are sort of worse than ours in terms of infection, maybe they can look at their resistance patterns and sort of rethink things.